The COVID-19 pandemic has led to a lot of innovation on the fly, and a lot of that technology is going to stick around, especially for things like remote work, analytics, and digital transformation. Here are 3 CXOs on how they managed the pandemic and what we can learn from them. First up is Verizon HR Chief Christy Pambianchi on remote work. Hi, I'm here with Christy Pambianchi. She is head of HR at Verizon, and she's just recently moved a bunch of people to remote work. And she's going to talk about some of the takeaways and, things to ponder as, for CXO leaders. Hi, Christy, how you doing?
I'm great, and thanks so much for having me here with you today, and happy to talk about what we're trying to do here at Verizon in these really trying and new times for all of us.
So let's start at the top. How many folks did you have to move to be remote workers in the last 2 weeks or so?
This is really unbelievable. We have 135,000 employees worldwide. Before we got into the coronavirus crisis response mechanism, we only had about 4,000 people that were our home-based agents working from a home environment. And over the last 10 days or so now, we've moved over 110,000 of our employees to be in a work-at-home setup. So this has been just a shift of monumental proportions that I think if we asked ourselves 10 days ago, we wouldn't have thought we were capable of.
So did you move call centers, admin function? I guess what functions had to go remote?
Yeah, we tried wherever possible to put work remote. And so we just took a position that said we want everything to move to a work at home environment that can. And so that was the starting point. And so we've moved telesales, customer care, solution specialists, all of our staff functions to a remote environment. We have functions like information technology, our global technology solutions teams, they're moving to work at home. We also moved a lot of our retail associates. We've right now, to comply with shelter in place and closure orders around the world, we have our retail stores here in the US, 70% of them closed. But the associates that work in those stores, we're enabling them to be able to contact their customers, work through the VZ Verizon application to find ways to give them solutions that they need. And so we really have left not working from home our field technicians that are out keeping the network connected and doing the construction and the support work for that, as well as those visits to small businesses and enterprise and governments and homes that have to be done to keep the homes connected in this crisis. And so we've really taken a position of let's figure out how to do everything at home. And these call centers and these teams that we've enabled to work at home previously were not. And we have been shifting all of our training that we did in person to virtual so that we could deliver on the fly training to people for how to do their job at home. And just this past week, we had 25,000 people that we put through virtual trainings for how to do their roles from home, and more to come next week. So I think for us, this has really been story of what the power of people can do when we all just work together and say we don't really have a choice. We're going to just have to figure this out at speed. And with so many school systems and other care systems closing as well, we're asking people to be a lot more patient and flexible. There might be a dog barking in the background. There might be some kids in the home that are now being homeschooled, so to speak, myself included. I have 4 kids, and 2 are home from college, 2 are home from middle and high school, and I know many families have that throughout the world. So really been a flip at speed.
What were some of the enabling technologies for this sort of big move? Like, did you have collaboration tools in place already? I guess how was, were the technologies you had to add to make this move happen, or were they all kind of in place?
I would say our technology support team has been very creative. We had some platforms that were able to be used like we had with our home-based agents, but we couldn't scale that fast enough for the tens of thousands of people we had to support. Some of it involved getting laptops and cameras to folks so they could enable online work and support from home. Some of it enabled like certain VPN or other capabilities to come in, Citrix, other ways to get into the network that we've been creative about. Also, we've gone to, even for our frontline folks, home garaging, where instead of coming in every single day to the central office in the garage to get dispatch tickets and tools and equipment for the day. We're trying to load those up by week so people can be home-based and do their role from their home every day. We've also obviously a lot of video collaboration platforms, and we use a number of them. So we've amped that up. And then our technology teams are putting out communications for folks, learning sessions to like how to work remote, how to do effective video conference calls, how to do effective communications in this new kind of world order for now. And then I think the other thing we've done is really tried to create one source for everybody to go to. So we created a coronavirus webpage that was internal, and then we began to put a coronavirus external page on about 3 weeks ago. We've moved all of the internal and external to be accessible from the external public webpage. And that way, every day we tell our employees it's updated every day, go there, people can find information. And then we have something called Verizon Up to Speed, where every day we do a broadcast for our employees to hear from the CEO and other leaders of his team like myself. And we take questions. We started an Ask Christy box so people can ask me anything they're not getting the answer to. We actually had to close our fitness centers, but our trainers are making videos and put them online for our employees to see how to do some fitness routines. And teams are finding ways to use all those other products and capabilities that they didn't use every day in their work before.
What have been some of the cultural hurdles, or I guess what are some of the things that have surprised you throughout this?
We had, I think we had some predisposed, we call them like orthodoxies, and some of the things we've been doing in our company to find new ways of working over the last year in our own transformation, has been to say, hey, let's identify orthodoxies and let's figure out why we can't change our frame of mind. And I think this move at speed to how do we pivot our organization to support our customers, keep our network up and running, work with each other in a way that's virtual, I think is forcing us to slay a lot of orthodoxies. And so, I think like a lot of organizations, we definitely place a high premium on face-to-face meetings. We do a lot of travel to be with each other, be with our customers, be out in the market with businesses and products that we provide and support. We like to see our customers in person, and with a shelter in place order as a way to control and prevent the spread of coronavirus, that really kind of puts a severe limitation on that. And so we've been doing and conducting a lot of business through oral communication or video communication, and finding out it's not as bad of a substitute as people might have thought. And I think teams are connecting in new ways, personally and professionally. And I think we will continue to place a high premium on when we are able to reconnect physically and be in person with our colleagues or our customers. But we may also, once you don't have something, you realize how much you value it. So it'll probably be a premium. And then this opportunity to allow so many other individuals to do their role remote, we might learn a lot of things out of that too. So I'm kind of excited about looking at this as an innovation opportunity versus just a disruption. It's obviously clearly a disruption. I think we all feel the call to action to help all of our fellow citizens and reduce the spread of coronavirus. And then for us at Verizon, we feel the call to action to keep the networks up. I mean, with so many workers moved to home, so many kids moved to home school, now more than ever, people are calling for bandwidth. We see it in the network utilization and the amount of videos and text messaging and even voice calling. So we have this kind of interesting time that we're in. So that's what I would say. We're learning a lot of new things.
Yeah, my working theory is that this whole move remote is probably going to change a bunch of things into the future. One, I think a lot more people will stay remote. I do wonder things about commercial real estate, things like that. As you watch this unfold, what do you think will stay, and what do you think will revert back to the way it was, pre-COVID?
Yeah, that's a great question. I think for us, one of the things that we have been trying to transform inside Verizon up until now was that people could have leadership roles and functions could be conducted, all over the world in the different markets that we serve. There had been an emphasis toward having all the leaders co-located the decade preceding. And I think something like this proves out that we could be effective and have teams work cross time zone, cross geography, and stay connected digitally. So I think that's a really good thing, because there's a lot of talent, and a lot of talent want to, be their best and have all the opportunities available to them. So I think it'll create more fluidity there. That's a good thing. I think another thing is, for remote workers, they often have, historically, when I do like employee pulse surveys and things like that, they always feel like an afterthought, or maybe left out, or maybe, and there's a whole body of research around how do you run distributed teams. So I feel like people are getting that muscle now. I think another thing that's going to stick is the idea that you can do temporary assignments, or joblets, I like to call them. So we're about to launch next week, using our internal recruiting platform, the opportunity for managers and employees alike to post, hey, I could use some help for 5 hours on this assignment, or I'm building a team to do this, and people will be able to access and go, hey, I might have some downtime, I could fill in with that. And so it's going to create almost like an internal labor market for short-term tasks or assignments. And we're so used to like walking down the hall, seeing our teams, rounding up everybody in a room, talking about who has capacity. And now we're going to probably, hopefully, create a virtual market for that, which I think is very exciting and will be very empowering to people. And I think those could be some innovations that come out of this that could be really positive.
What are some of your management takeaways, for kind of best practices? And I mean, because everybody's wrestling with managing remote teams and things like that. I guess, what are some of your early takeaways with this big, I call it a big A/B test almost?
Yeah, I think for folks that haven't ever managed distributed teams, or teams cross time zones, or teams in a remote environment, people do have to learn to set some boundaries. So that's typically a learning. So, hey, just because I'm working from home, I maybe don't want to be on a 7 a.m. call and an 8 p.m. call. So, and that's some of the growing pains that typically multi-time zone distributed team orgs go through, or, our Europe teams never appreciate it when we do like all of our team meetings at Friday at 4 o'clock. That's like their Friday evening. So I think there's some of those typical growing pains for global and remote teams that I think we'll get. I think another is, how do you, for example, I've been trying where we're using video technology in meetings to say, let's everybody go on mute. Let's hear the presenter. Let's use the chat feature so people can add comments and chat throughout, and then appoint someone to be the moderator to then ask the presenter the questions that have come in. So the kind of 10, 20 people coming off mute trying to talk at the same time, not that effective. So I think we're learning some of those. They sound basic, but they can make a meeting be very, very efficient and fun for people. And then I think the other thing is we do really like having, and I think it's important for our company, and I think a lot of companies do, we'd like to have the human be a part of the workplace, so it's not just come in and be a worker and complete your task, but there's a whole human element to the workplace. So we're trying to find ways to bring those elements in. Maybe at the coffee pot, I would sit and chat with someone and hear how their weekend was, or what their kids were up to, or how they're personally doing. And so we're trying to create some fun social interactions inside of the workplace as well, to add that element of the workplace back in a remote way. So it could be people send us in photos of what you're doing, or join the virtual workout, or take this. Just yesterday, people were sending around physical challenges, like who could do 10 push-ups and post a picture, or send me your furry friends, or who's trying to make their kids do the homeschool and be doing a work meeting. So I think not losing the human element of the workplace, but finding a way to do it virtually is kind of cool too.
Definitely. Is there anything I didn't ask that I should have, or any final words for this big remote move?
My main message that I would love to just add as a close for any of the viewers is really just patience. And this is a new for some people. Most of the questions I get asked, and people, they have my email, they have my cell number, there's an Ask Christy box. I have a team of people in HR helping me respond. We update the web every day. And most of what I experience on those is fear. and people are scared right now. And so I think one of the things we're trying to do for our employees at Verizon is give them a constant set of information we know of to be the most current on our webpage. And then we're just encouraging our coworkers to be patient with each other because stress and anxiety comes out in different ways. And as everybody's flipping to this new normal, while also facing what may be some personal risks, we're trying to make sure we just all exercise patience with each other. And I would just share that as a personal close. And I think this is really where humanity will show itself, where we come together. The only way we'll solve this crisis and reduce the loss of life is by all collectively participating in the solution.
Okay, thanks for joining us.
Thank you so much for having me.
The next interview is ESO Chief Medical Officer Dr. Brent Myers on analytics and how it informs the EMS to hospital handoffs. We're here with Brent Myers. He is Chief Medical Officer of ESO. It's a company that basically aggregates clinical data for first responders. Hi, Brent. Thanks for joining us.
Great to be here. Thanks for having me.
So walk me through a little background of what ESO does and how it connects hospitals and first responders.
Sure. Our company was founded in 2004 by a paramedic and a computer programmer, basically, who realized that the data being aggregated in the clinical care for EMS was really hard to share, both internally within an agency, as well as externally to hospitals and other partners. And since that time, we have become one of the largest providers of data aggregation. So we provide an electronic medical record for firefighters and paramedics. And then we now aggregate that at the hospital side, not only for patient care in the emergency department, but for registries, repositories, research, and data across the United States.
So you recently released some interesting data that it's an interesting data dashboard on the COVID response and how it's impacting EMS and sort of what they're seeing. So I think what interested me the most about the data set was just that it kind of shows you what's actually happening versus like a projection. So I guess walk us through the data and kind of the big takeaways there.
Sure, great. And what we did back in March the 6th is that we added COVID primary impressions. And there's a technical reason that paramedics don't use the word diagnosis that's probably on this conversation. But for the purposes of analogy, it's like the paramedic's diagnosis. We call it an impression at the federal level. And we gave the medics the ability to say, we are either suspicious that this is COVID or this patient has already been tested and we know that they are COVID positive at the time of the encounter. So from there, we've been able to aggregate data around the care that these patients receive. And it is very consistent with some of the projections that we've seen around the country. And then it's also very consistent with data that we've seen internationally from China, Italy, and elsewhere, meaning that only about 10% of the patients that we encounter actually require EMS intervention. Most of them are actually quite stable and do very well. And then about 2 to 3% are critically ill across the country. Now, obviously in hotspots, that's not exactly the same, but if you're preparing as an EMS administrator to think about what do I need to respond in an average community across the United States, not in a particular hotspot, we're giving folks a lot of data about the clinical preparedness. So we think that's important. The other piece is obviously responders need personal protective equipment. And what we've learned, not unsurprisingly, is that they need personal protective equipment not only on calls that are highly suspicious for COVID, but because you don't know really until you interview the patient if they're at a high risk or not, you're having to wear personal protective equipment on many more responses than you did in the past. And indeed, in some communities where there's a high prevalence of disease, they're wearing personal protective equipment on every call. And obviously, hospitals need personal protective equipment, clinics need them as well. So we're trying to provide realistic data to help the federal policymakers understand how much EMS is going to need versus the other components of the healthcare system. So those are the kind of major things we're looking at.
Yeah, because most of the data to date is focused on the hospitals and the front lines there, not necessarily the EMS and the folks getting them to the hospitals, correct?
That's right. And we have worked with our federal partners and other partners within our industry, individuals that historically would be competitors of ours. We're now working together to aggregate these data to tell a consistent singular story about how much PPE responders are utilizing. And I think it's important even now at this stage to think about how often they're having to reuse personal protective equipment. In other words, it's not necessarily that they are completely out of personal protective equipment, but when they look at their projections, they realize that to conserve certain elements, we need to reuse. And there's a whole debate about how long one can do that and so forth. But our preliminary data shows that about a third of the time with the N95 mask that many people have seen on television, and Governor Como and others speak about a third of the time our EMS providers are reusing a mask from prior in that day or prior in that shift, rather than choosing to use a new one in an attempt to help preserve the supply for the next month or two, or however long we may need them.
So your data set, how much of it is based on the actual, I guess the unstructured data from the 911 call?
So the great thing about EMS across the country is years ago, the national EMS data set was established. So there is a not free text, but structured data elements that are required for every EMS call. And those become more sophisticated with iterations. We're at version, depending on where you're on the country, 3.2 or 3.3 now. We're moving to 3.5 in the future. And each one of those iterations gives us better structured data that allows for more objective decision making. Because we are also the vendor of the software into which the paramedics and firefighters enter their data, we can control even beyond the NMSIS elements, the core elements, and bring those data in a structured manner. So what we are reviewing on our website and at the COVID Resource Center we put together is all structured data. We do have the capability with natural language processing and other ways to extract from the unstructured data that may be in the narrative where the medics telling the story of the call, but it's a drop down menu where they choose their personal protective equipment or where they choose their medications or their critical interventions, so that it's easily queryable and reproducible.
Okay, so over time, do you see, I guess, what do you see as more valuable? Is it that structured data set that's sort of been created for a while, or will it be the unstructured over time?
The structured data is going to be much more important, and the beauty that we've learned here is how nimble you can actually be with adding structured data elements. Some of these we added to the software and deployed across the country within 24 hours of request. For example, the reuse. We had lots of requests so that the administrators could really determine how many new masks do I need to purchase. So we added those reuse elements in a very short period of time, but we also make it in an easy drop-down menu so that the medics have an easier time. Where the interesting part comes is in the EMS to hospital interface. Historically, keeping that EMS record matched to a patient going through the ED so the emergency physician could have the data available about what happened in the out-of-hospital environment was very difficult. That is now also coming in a structured manner. But on the outbound data back to EMS to learn about outcomes, we're working through unstructured data in that manner. So getting more sophisticated about the outbound data back to the medic so they can learn what happened to their patient and improve. That's where we're really working that fine line between structured and unstructured, because the hospital language is just different than EMS, clearly.
Right. So the electronic health records and the EMS data, are they interoperable these days? And I guess what's there now and what needs to evolve over time?
So great question. So historically, the hospitals were used to receiving a printed run record. And there was a period where, and this is just the facts of the case, where EMS would create an electronic record. It would then be printed, handed over to a unit clerk in the emergency department, only to be scanned back into the hospital medical record as a PDF. Which Ouch. Is kind of, that's just painful, right? And that was the most common way that this was occurring across the country. So the first step was, we're going to recreate the PDF and send it to you electronically. So at least we're not going through, paper and papyrus and all that step, right? And so that's what the hospitals were comfortable with. What we found over the past 2 to 3 years is the richness of the EMS data and the ability to predict how to care for things like sepsis, for example, where IV fluid resuscitation is so important. Know how much fluid was given by the medic helps the hospital determine how much additional IV fluid is needed. So now we're sending discrete data elements into the hospital medical record. So we know the temperature the medic obtained, the blood pressure, the medications that were provided, and we're receiving that back from the hospitals discreetly. So I would say there's some absolute best practices that are occurring now across the country where that is occurring. The ONC at CMS is really focused on this issue, and we just prior to the COVID outbreak, we had a summit in DC, a day-long summit around this exact issue to move from kind of non-structured PDF type data in and out of the hospital, but to true discrete data elements, and we're making lots of progress in that way.
How are new technologies like 5G and those sort of things helping the data sharing between first responders and hospitals?
So two major ways that 5G is going to help us. The first of those is that when you have a lower bandwidth or in some cases a completely non-connected environment, obviously some of the data has to live at least temporarily on whatever device the medic is entering the data. And so when we want to push an update, such as the reuse drop-down menu, we have to wait on connectivity. And so our ability to be nimble and move quickly with updates pushing out to the field. And it also really has difficulty about which types of devices the medic can use. And, can you go all the way to a pure tablet device when we have to be able to store some of the data in a non-connected environment? So 5G helps with that tremendously. The other piece that we're really excited about is the telemedicine component, so that there's enough bandwidth, if you will, to share things like an EKG tracing in real time or an ultrasound in real time, and for the physician to be able to do an exam on for example, a stroke patient in a remote manner to determine the best hospital destination for that patient. And the ability to do that without worrying about bandwidth and all of that is going to be tremendous for us.
So if we play this out, 5G covers every place, rolls out a lot more. You could literally have an EMS worker and then a doctor on a video call in the ambulance before they even get to the ER?
Absolutely. And as a matter of fact, there's a federal program now that they were supposed to roll out in 2 or 3 months. It's probably going to push because of COVID, but it's called ET3, and it's an innovation project from CMS. And the notion there is that we are definitely going to support the medic, not only in the acute patient that's coming in that may help prepare for stroke or trauma or that type of thing, but also for the very low acuity patient. You can also have a telemedicine visit and perhaps avoid the transport altogether. So it's kind of both ends of the spectrum. That telemedicine piece is really important.
Okay. As this evolves, how do you think the COVID pandemic will impact? I guess how do you think it will impact data sharing overall? I mean, I've been collecting some of these data sets and visualizations and it's really nice to see all the data sharing and, I guess we're all data scientists at this point. How do you think the pandemic changes, not only the data sharing in your neck of the woods, but also across the health profession overall?
I think that, the fundamental of never waste a crisis, this is one of those opportunities to demonstrate that the concerns about privacy are very important, and we can never forget those, right? I mean, this is personal health information. We have to have the security. We have to make sure that whoever's looking on the other side has a reason to look and all of those things. I think, however, the pendulum historically has swung a little too far, and we've been overly concerned about things that, quite frankly, patients would be perfectly happy that we would share. In other words, if sharing data in aggregate in a de-identified manner, so that we're not individually identifying a patient, but we can say in this community, we are 6 days away from trouble, and it may not be COVID, it may be whatever it is. The ability to plan at that level, at the macro level, and not be surprised is I think where we will land on the other side of this. And again, I'm not downplaying the importance of HIPAA and all the needs to protect a patient, but there are ways to share the data that don't violate that and that protect the patient's identity, but that allow people at the local, regional, and even national level to be much better prepared going forward. So that's where I think we'll be. And the ultimate goal of that would be for that medic at the bedside to have decision support to say, I have a patient with the following illness. Where is the best place? And does that best place have a bed for me now? And if so, what's the best way to get my patient there? Is it by air, by ground? All of those options that could be in the hand of the medic at the EMS level. And then the same thing at a clinic, an urgent care. It could go across the healthcare system to do that bedside decision support.
Okay. Any final points to add that I didn't ask?
The most important thing here is, I think, using these data allow us from the EMS and out of hospital perspective to appropriately make requests during this current outbreak. We don't want to be the ones that say we have to have every piece of personal protective equipment, because obviously our colleagues in the hospital and elsewhere need those. But the ability to appropriately make requests and appropriately plan as our slice of the healthcare continuum, I think, is very important in the near term. And then to your point, the far term is getting much better.
All right. Thanks for joining us.
Thank you.
And finally, we have Nebraska Medical CIO Brian Lancaster on how his digital transformation projects paid off during the pandemic. Hi, we're here with Brian Lancaster. He is CIO of Nebraska Medicine, which oversees a research arm and the hospital. Hi, Brian. Thanks for joining us.
Hi, thanks for having me.
So I guess walk me through Nebraska Medicine and, what's the hospital part versus what's the university part?
Yeah, so to be fair, Nebraska Medicine is the clinical enterprise. It's our health system. And then our academic partner who does research and education is the University of Nebraska Medical Center. So those are two different entities, but in essence, we operate as, for all intents and purposes, as one.
So you oversee the technology for both sides, right?
I do, yes.
So walk me through, the COVID-19 response, and how you had to move people remote from, I guess from two perspectives. One's the university side, the other one's the clinical side. And, I assume the moving parts are vastly different.
They are vastly different, but related. So one of our complexities is one person could be a clinician, a teacher, a researcher. So they do all three of those different businesses, and they have different needs depending on what role they're in at that point in time. So as we approached kind of what I would call digital transformation, we've actually been on this journey for the last 4 or 5 years with working on automating our data center, making sure we're using private cloud techniques, allowing us to re-architect our remote access and deploy legacy systems via web portals and things like that. So we've been working on this for quite some time. And fortunately, I think we had done the preparation to allow us to quickly move to keep teaching, keep researching, keep caring while remote. So that's, kind of the ounce of prevention is worth a pound of cure. We've been able, mainly due to work we did last summer, to kind of move everyone to a new remote access point that we branded as a digital campus, and then also as a work anywhere, anytime strategy. So that I think was very successful in allowing us to prepare for COVID-19.
So what technologies did you use to, sort of re-architect?
So from the data center perspective, so mainly the technologies we use were from the VMware stack. So kind of the virtualization in terms of our server infrastructure, and then our network infrastructure, NSX, vRealize Ops, vSphere, kind of those components. And then to the user, which was a big push this past summer, was Workspace ONE. So being able to take all that together and then expose it to the user. So if they're using a web client, a mobile client, or a legacy system, it all appears to them as kind of in that portal from a one-stop shop perspective.
And as far as what are the nuances for, clinical workers in the field? Because I know some hospitals, are moving certain types of workers remote, like whether it be social workers, and there's some moving parts there about what can go remote and what can't. What are some of the nuances when it comes to supporting that?
Yeah, so there's lots of considerations. So usually this gets quickly into the field of telehealth. So anything that was elective basically went to either be canceled or to a telehealth platform. So telehealth falls into two different types. One is referred to as asynchronous. So I could ask you a set of questions that goes into a queue, a provider picks it up and then responds. And that actually works pretty well with things like strep throat or to do an initial COVID-19 screen. So we've been using those asynchronous capabilities to do that, which basically was done through mobile app development and then also partnerships with our electronic medical record. Then I think what most people think about telehealth is real-time visits, so video visits. So basically what we did over the course of a couple weeks was shifted all of our scheduled ambulatory, so office visits, to be real-time video visits. And we basically did that through a Nebraska Medicine app, our digital front door, and then partnering with our electronic medical record, which is Epic, and then also Zoom technologies for the video visits.
Okay. How does HIPAA fit into this in terms of, I know some of that was relaxed with COVID and, you know, a bunch of, you know, things like that, but, you know, how does the HIPAA, you know, fit into the equation?
So I think both HIPAA and having a good security posture play into that, meaning just because HIPAA regulations are relaxed doesn't mean we want to, in essence, expose a new vulnerability to us from a cyber attack. And if you're not aware, cyber attacks are probably the highest they have been now for any industry, but certainly for healthcare. So we want to make sure we have a strong security posture, in addition to making sure we can address any HIPAA issues, even if those HIPAA issues have been released or relaxed, mainly because once we let telehealth out of the bottle per se, I think both our patients and our providers will want to do it because it's extremely convenient. So if we allow for a non-HIPAA compliant solution now, it'll be really hard to introduce security controls that we can control at some point in the future. So in essence, we're only allowing for the exceptions if it's truly an exception, like you attempted to use our HIPAA compliant approach and then it failed, we may allow for a one-off or something like that.
How do you work through the video conferencing stuff part of telehealth? Is it a case of shielding the connection, or is it more about the video conferencing, or is it more that it's integrated with, you know, some system that's HIPAA compliant? I guess how does that work with the telehealth?
Yeah, so the endpoints are all protected in kind of a HIPAA compliant deployment. So basically, we're using a system from our electronic medical record called MyChart that we've been basically embedded Zoom into. So MyChart has been HIPAA compliant and secure for decades, and now we can enable and turn on those video visits through it, if that makes sense.
Okay, so it kind of takes the video conferencing solution out of the equation, basically. Like it wouldn't matter if it were Zoom or BlueJeans or Microsoft Teams or whatever, it would be compliant because it's within the MyChart?
Yes, with a caveat. So
Okay.
There's only two solutions that I'm aware of that are compliant with MyChart, the Epic solution. That would be VidYO and Zoom. So that kind of obsoletes the ability to use Teams if we wanted to make sure it was HIPAA compliant in a future state. If that makes sense.
Yeah, so it's more about the integration with the basically electronic health record system.
Correct. And then we used a SDK from Epic MyChart to, in essence, create a Nebraska Medicine app. So the patients are working directly with it. When they click the video visit, it basically just seamlessly goes into Zoom versus having them to install Zoom and things to that effect.
What about the technology front for the people that are, you know, truly on the front line supporting COVID patients? I guess what's changed since, since the outbreak, from a technology front?
And this is where I think we've done a lot of innovation, which I haven't seen other healthcare providers do. So when you're in the hospital, there's basically been a restriction of visitors because we don't want people who may be asymptomatic carrying the virus to come into the hospital and things of that effect. I mean, it's basically the quarantine order broadly, right? So what that has done is when you have a person a loved one in the ICU, it's really restricted ability for family members. And it's also requiring our physicians to use protective PPE, protective equipment to go into the rooms. So what we've done, and I haven't seen too many other people do this, is we're basically allowing the patient to get an iPad that has telehealth capabilities built into it. So the provider, the first respondent who's rounding on that patient can use telehealth and not physically go into the room. So that saves a mask or a glove or whatever that equipment might be. It also allows us to have loved ones kind of listen into the conversation, and also allows loved ones to have interactions with their patients. And to put this into, I think that what's happening is we've had unfortunately a lot of patients coming to end of life. And if we didn't have that technology, that telehealth component to allow for the loved one to come in and have that last moment, they wouldn't have had that last moment. So both have been a way for healing for the family. It's also been a way that we've saved PPE because the physician and the care team can round on a patient without actually physically going into the room.
Was that in place before this, or was that something you improvised on the fly?
So this is probably the big story behind all of this. We've had a lot of this in place for a while. So we had a ability for a patient to get an iPad to manage their care, so they can see what they're scheduled for. They communicate with the care team, and basically the way that worked is we had a docking station that is controlled by a technology called ground control. Allows us to badge tap in, clean the device for a new patient, hand the patient the device, and they can manage their care. We had very little adoption of that technology. Both the care team and the patients weren't really too interested in it, which is interesting. Now we've seen a hockey stick up in terms of the adoption, meaning people are really embracing it and really appreciating it. And that's both on the telehealth capabilities on the inpatient side, as well as on the ambulatory side, the office visit side. We used to have to kind of entice physicians to want to do telehealth. Now it's basically went from 1 to 2% of our activities to 100% of our activities. So we're really seeing a widespread adoption. So our technology pieces have been rock solid. However, the change control pieces have still needed to be embraced. So it's a lot of training, adoption on the fly, a lot of user questions, and how do I do this? How to do that? What if this happens? And I think that's what we're working through right now is some of the softer points of the rollout, because we really didn't adopt it to the level we needed to prior to this event, if that makes sense.
So was that a project that would have looked like a flop pre-COVID, or it would have been like a long-term project without, a ton of runway, and then COVID happens, and now it looks like, you had a crystal ball almost?
Yeah, absolutely. And both from the remote work as well as the telehealth component, we were pushing for it from a leadership perspective and from an IT perspective, because we believe that digital is going to transform our business, but it was always a 1 to 2% so far. So it was, I want to work occasionally from home, or I might want to pick up 2 or 3 visits a day to do from a telehealth perspective. So we saw little adoption. So I think COVID-19 has really driven digital transformation in healthcare. We had to figure out how to do remote work. We had to figure out how to do telehealth. And I'm thankful that my leadership team had the foresight to invest in these technologies, and that investment I think is paying dividends right now. And I think post COVID-19, nothing goes back to normal. Meaning, I think our patients and providers who are now been experiencing the benefits of telehealth, they won't go back to, the waiting room, waiting 30 minutes for their visit and those sorts of things. They're going to demand asynchronous and synchronous visits, and our providers will now want to do that too because they see the value in it. So I think it probably would have been seen as a flop or as a innovation, an R&D project. Now it's kind of table stakes.
Right. So what do you think, you mentioned the new normal. How do you see this playing out in terms of, the post-COVID landscape? Is it going to be, are we all going to rush back to work? Is there sort of some hybrid medium kind of state? I mean, I look at this too, right? I have a remote team. I had a remote team before. We're still obviously remote. So, nothing really changes per se, but, as we model out sort of everybody getting back to work, I do wonder how much sticks and how much, it won't be the way it was, but I'm just curious to get your thoughts on, how do you think it'll play out?
Well, I mean, I think there will be some slow return to work in a hybrid fashion just because of managing the virus. I think that's going to play out for the next several months, unfortunately. But if you take that off the table, in my opinion, and this is one of the reasons I was so gung-ho, so pushing for this type of technology, is if you just look at the space we have at Nebraska Medicine, at the University of Nebraska Medical Center, we're running out of space. So it's very costly space, and I'm in Omaha, so I'll gripe about my 45-minute drive, but it's still 45 minutes, an hour and a half a day, which would be fantastic in other aspects of the country. But why waste that time if I can be productive at home? And so I think we were pushing for it to save on space, to have a sustainability impact, and then also to be more productive. And so I think now that people have been forced into it, they'll see the value in doing it. And I think you'll see, likely a more of a hybrid rise in all roles doing remote work, not just technology-based roles. And I think that'll also get to a change to what our physical space at work looks like. And you see this with more in the startups and the technology firms. But I would push for this back at Nebraska Medicine. How do we create maybe not named offices, but shared space for workers that you can, when you need to have an in-person meeting or a collaboration for whatever reason, you can go reserve it or go pick it up and just use it, but you don't have dedicated space, which I think would save us a lot of capital money. And I think it will also allow us to be more productive.
Yeah, I mean, I've been seeing the CFO surveys, and that's pretty much where things seem to be going, right? It kind of looks like a win-win for the worker and the company. So yeah, is there anything I didn't ask that I should have?
I think you covered most of it. I do think a lot of this gets into kind of a cloud strategy to some extent. So one of the reasons it took us 4 to 5 years to get to this point was all the kind of the cloud work we had been doing. And for us, cloud work is mainly private cloud with then adoption of SaaS systems, and then to expose those to an end user in a way that looks seamless. And that's really what we did in the last little bit here, the last mile, if you will, through our remote access work. But I think that all ties onto a cloud strategy, if that wasn't clear from the earlier remarks.
All right. Well, thanks for joining us.
Thanks for having me.